golden dent.
And I'm simply engaging the beak on the palatal aspect of this tooth. Now you must have a purchase point. If the tooth is elliptical in some respect, then I will take a 557 surgical burr and flatten the root. I'm not damaging bone. Bone is gold to me, especially the interseptal bone, which is really important in the aesthetic zone. So I engage the beak. I put the bumper as high up the vestibule here, and I am not squeezing this instrument. I wish they didn't even call it a forceps. I wish they called it a luxator, because you're not putting pressure by squeezing the handles. You're simply rotating your wrist in this situation towards the left eye. Very, very effective. We're creating tension on the palatal aspect of this root, which is resulting in a physiologic response. The body is going to release an enzyme, which is going to break down the periodontal ligament. What's holding this tooth in place? The periodontal ligament. If we destroy the periodontal ligament, the tooth is going to pop. You're not going to hear a pop. It's going to pop up and out of the socket. You can see how it's following that arc of rotation. The instrument is not intended to remove the tooth in total. Rather, it's intended to luxate the tooth up and out of the socket. I will then take what we call a tooth delivery instrument. I'm simply grabbing on. Now at this juncture, this is maybe a 1.5 minute procedure. And I'm simply removing the tooth in total. So I'm not sectioning, and I'm certainly not damaging the interseptal bone in this area. A very effective, very efficient, and very atraumatic or minimally traumatic to the tissue around the site, to the patient, who oftentimes isn't even aware that I took the tooth out. I did several patients today, and the patients look at you and they go, you're kidding, right? Because they're used to extractions being very, very traumatic to them. If it's not traumatic to the bone, if it's not traumatic to the patient, it's relatively atraumatic to the doctor. And that's what I truly appreciate about the instrument. You can see these divergent roots, and we're able to remove this tooth quite efficiently in a couple minutes, very efficiently, removing the infected tissue in total, and not having to work all that hard. In this situation, one of my favorite osteoplastic materials is called Osteogen, and you can get this through Golden Dent. It is a material that is a bioactive calcium apatite material in a bovine Achilles tendon matrix, and the material actually mimics the organic and inorganic components of physiologic bone. The bovine Achilles tendon is simply a collagen carrier, and prevents invagination of epithelium. Tissue, when we graft a site, there's always a race between bone growth and epithelium invagination into the socket. I said earlier that bone heals or integrates from the apical portion towards the crest. The epithelium will go from the crest towards the apex, and it's a race. Well, epithelium grows up to 10 times faster than bone, so we must protect, in most situations, our grafting material from invagination of epithelium. And how do we do that? We do that with either a membrane or with this synthetic material, this calcium apatite. The bovine Achilles tendon carrier actually prevents epithelium invagination into the socket. The epithelium will follow the path of least resistance. You can either go in or on top of it, and it will simply choose to go on top of it. So this is a material, and I don't know exactly what reward Kurt from Golden Dent's going to give you today, but it's a material that's maybe a $40 or $50 plug that is very, very simple to place into the socket. So what do you charge the patient? For those patients that you want to graft, you don't want the sinus to collapse in that area, right? We know if you remove a tooth root, the tooth root acts like a tent pole holding up a circus tent. If you remove the tent pole, the circus tent's going to collapse. So placing a graft material and protecting it is really, really important for a future implant. It really makes socket preservation easy and affordable. There's two sizes, a large and a small, and I would talk to Kurt and his team to see what kind of special they can give you and get a wide variety of both types. This is how it's packaged. We'll undo the package, and it's simply like a plug. It's not like a collagen plug that you can get very inexpensively. The collagen plugs are normally derived, again, from a bovine dermis, but these collagen plugs, inexpensive ones, resorb rather quickly. They turn into snot, essentially, in a very short amount of time, anywhere from a few days to 30 days. And they're good for clotting, but they're not good for bone growth. When we're grafting, we need to protect that graft from invagination of epithelium for a minimum of 6 weeks. These are important numbers to remember. And so a material that's only going to last a few days to a month is not going to cut it. So anyways, let's go back to the Osteogen plug. You can see it's rather firm. It's not like a styrofoam exactly. And you can see what I did was I cut the edge and I made it look like the root of the tooth that I just extracted. Cool photograph. And again, we've talked about this. We're going to plug this material into the sockets. Now, you could cut this into 3 pieces and then put the 3 individual pieces in, but here I'm showing off a little bit and made it look like the socket. We're going to place it into the socket firmly. We're not condensing it like amalgam, rather than we're condensing it firmly, and then we're going to protect it with a couple sutures so that it doesn't fall out. Now, it's important that you tell your patients that this graft material, this synthetic material, calcium apatite made in a laboratory, is white in color, as is our allograft material, as is our membranes. You want to tell them that. It's very important, because someone's going to look in their mouth and they're going to see something white, and they're going to think it's pus or infection, and they're going to poke it or play with it. It's supposed to be there, leave it there. Again, remember what I said. Epithelium grows 0.5 millimeter to 1 millimeter a day. So if you have an opening, we do not need primary closure with these materials. Let's say we have a 5 millimeter or 6 millimeter opening. You know it's going to take about 12 days for that to close over completely. So just be aware of that. The material is somewhat radio opaque, so that you can see the transformation, as I showed in that first set of radiographs, how the bone will turn over a relatively short amount of time. So we have the tooth taken out, and it's very, very important. This technique is important. We must curette, 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 curette. You want to remove any granulation from the socket site, any purple blood. Red blood is good. And you can see I'm just picking out that huge granulomatous mass that was in that socket. You want to clean all of that out. Yuck. And then here I'm simply taking my Osteogen plug to site, and I'm slowly letting the blood absorb into it and pushing it into that socket and plugging it, not like amalgam, not crushing it, but firmly to the crest of the ridge. Now I want to protect this material, and I'm simply going to suture, place a couple sutures here in this site. And I want you to see how I'm suturing. I'm taking my reverse cutting needle, and I'm going from the crestal portion, and I'm sliding it over the top of the graft to the facial, and doing the same on the lingual. That way I'm not going to grab onto the material. And you can see I just put a couple interrupted sutures to hold it in position.